everyone. My name is Chadi Alraies. Welcome to all in Coronary Physiology cardio webinar series. I would like to highlight a few things about the series. We started that last month, and this is the second episode. We're going to continue the discussion about every topic related to coronary physiology and intervention. The topic for this webinar is TCT 2020 update, incorporating current data and in your PCI practice. What we're going to try to do is we're going to discuss recently presented science at TCT 2020 meeting, highlighting physiology and optimal PCI in patients with complex coronary disease. With that, I have a very special guest, Dr. Barry Ritsky, Dr. Manos Berlakis, and Ivan Shlofmitz. We're going to kind of dissect this webinar into three sections. Dr. Shlofmitz will start by highlighting the TCT trials that was presented related to physiology and optimization of PCI. Will be followed by Dr. Berlakis presenting his intake on importance of physiology in practice with examples. And Dr. Barry Ritsky will finish the webinar by presenting case-based of visualization of PCI and physiology in the practice. With that, we'll start with Dr. Shlofmitz. Dr. Ivan Shlofmitz is an interventional cardiologist and the director of intravascular imaging at St. Francis Hospital. Is the Heart Center in Roslyn, New York. Dr. Shlofmitz's research interests have centered on intravascular imaging, physiology, and PCI optimization with more than 100 publications in peer-reviewed journal. Welcome, everyone. And Dr. Shlofmitz, if you would like to share your screen and take the panel.
Thank you so much for the kind introduction. Very excited to be here with this great panel. So over the next 20 minutes or so, we're going to review the data that was recently presented at TCT Connect. And there's a number of very important trials, and we'll try to give a quick overview and our commentary on those studies. These are my disclosures. So the studies that we're going to focus on this evening is Target FFR, which is presented by Damien Callison, the Forecast trial, which is presented by Nick Curzon, DEFINE PCI, presented by Dr. Manesh Patel, DEFINE Flow, presented by Niels Johnson, and lastly, Combine OCT FFR, presented by Elvin Keddy. So we'll try to summarize each trial in about 3 minutes or so. There's an enormous amount of data that had just been presented. And to kick things off, we're going to review the Target FFR trial, which was the trial of angiography versus pressure ratio guided enhancement techniques. And what the study question of the investigators was, can PIOS, or physiology-guided incremental optimization strategy, increase the proportion of patients that are achieving a final post-PCI FFR greater than 0.9? So for this study, it was a single center study that involved randomization of 260 total patients. All the patients received angina and quality of life questionnaires that was assessed prior to PCI. And there was a control group where post-PCI physiology measurements were acquired, but the operators were blinded to that data. And then in the group receiving the physiology-guided incremental optimization strategy, or PIOS, they had post-PCI physiology measurements. And if the target FFR was greater than 0.9, the procedure was considered complete. If the FFR was less than 0.9, further optimization based on the strategy was performed, and then determining the repeat FFR measurements determine whether or not the procedure was complete or further optimization was needed. Now, with 3 months, the patients were all given repeat questionnaires and compared to their baseline questionnaire. So what is this optimization strategy? Well, if FFR was less than 90, and hyperemic pullback showed diffuse atherosclerosis, no focal step-ups, the result was considered accepted, and no further optimization was required from the operators. Whereas if there was a hyperemic trans-stent gradient greater than 0.05, post-dilatation with a larger non-compliant balloon than had been previously performed at least 18 atmospheres was mandated by the protocol. And intracoronary imaging was recommended just at the operator's discretion. And then after any performance of post-dilatation, there was repeat hyperemic pullback. Now, the next step in the strategy, if there was a focal FFR increase greater than 0.05 within an unstented segment, so in the reference segments, the treatment was to implant an additional stent to cover the residual disease and then repeat the hyperemic pullback. And then lastly, if FFR was still less than 0.9, repeat hyperemic pullback, then you can incorporate any of the above criteria based on that finding. And then there was a true final hyperemic pullback. So the results of this study for target FFR after angiographic guided PCI, operators felt they achieved an optimal outcome and would otherwise be done, was impressive. 32% of patients had an FFR greater than 0.9. Now, a similar amount, 29% had FFR less than 0.8. So it really was impressive to me that only a third of patients are receiving a post-PCI FFR that's above the target despite angiographic optimization. And the investigators also found that based on the FFR pullback assessment, a substrate for further optimization was present in 46% of the patients that had been randomized to this PIO strategy. So if you remember, there was an arm of patients where based on the FFR pullback, it did not require further optimization, but here nearly half of the patients who had an inadequate post-PCI FFR had an opportunity for further optimization. Now, operators considered it appropriate to perform additional post-dilatation and stenting in 2/3 of the patients in this cohort. And there was a larger increase in FFR that was observed with stenting and, as compared to post-dilatation. So among those 40 cases, the mean FFR had increased from 0.76 to above 0.82. And there was also a CFR increase from 3 to 4. So in conclusions of target FFR, the majority of patients with angiographic acceptable PCI have a physiologically suboptimal outcome, as evidenced by final post-PCI FFR. And then in the intention to treat analysis, randomization of patients with an angiographically acceptable PCI result to an FFR-guided optimization strategy did not achieve a significant increase in the proportion of patients that had final FFR greater than 0.9. The PIO intervention strategy did, however, significantly reduce the proportion of patients that had a final FFR that was less than 0.8. And then in the subset of patients in whom that further intervention of either additional stent or post-dilatation was actually performed, the final post-PCI FFR and CFR both significantly increased. And that was the target FFR study.
So Ivan, I would like to stop you here. I mean, I just opened a discussion to the panel about this is really an eye-opening findings to have 1/3 of the patient not even achieving the target hyperemia, target therapeutic hyperemia. Was this a surprise to you? How often do you use post FFR in your practice? And if this is a call for us to routinely do that?
Well, you know, I think it's certainly to me, this was very surprising that a third of patients, it really was, you know, something that's eye-opening, as you said, because I think in routine practice, people don't check physiology post-PCI. We're barely getting the average operator check physiology before a procedure. So, you know, I think we have a long way to go, but this shows how important it is, and it supports the current data of how critical it is, and that it actually changes outcomes when you utilize that information. It's not just about checking, but incorporating that information. So
I have direct question to Dr. Burlakis. How comfortable you feeling to have a reliable wire to use for post-PCI to measure your physiology? Do you think it's PCI cause any damage or ballooning or stenting?
Absolutely. This is a great point. And I agree, actually, I share the same surprise that it was such a high proportion. 2/3 actually were not with an FFR of 0.9. So that's impressive. But I guess to do it accurately, you want to make sure you don't have as much drift. And actually during my talk, I'll talk about the importance of having not enough drift, because If you have drift, you have to recross the stent, and there's these issues there, or there's tortuosity or calcium, then that might be a problem thing. So having an FFR wire that actually has very little drift, that's critical, especially post-PCI. You have to disconnect it, you have to reconnect it. So if drift happens, then that can throw off entirely this investigation. I presume in the study that the investigators made sure there was equalization when they put back to the guide. But as it can be facilitated with a good wire, can make life a whole lot easier than if you have to rewire the lesion and start from scratch.
Perfect. Yeah. Thank you, Dr. Flex. All right, Ivan, would like to move forward?
Right, as we'll see with the later cases, it's not just drift, but also even a wire that's a good workhorse wire, so you're not having to change it out. If you're doing your PCI over a physiology wire, you're going to be more likely to check post PCI physiology. We'll hear more about that a little bit later. So moving along to the forecast study, fractional flow reserve derived from CT, coronary angiography, and the assessment and management of stable chest pain. So the study hypothesis, that didn't fully come through. So prior to this, no randomized trial had compared FFR-CT with routine assessment as part of an initial testing strategy in patients coming in with stable chest pain. And the study investigators asked the question of, will FFR-CT be a cost-effective initial strategy in patients with stable chest pain? Their hypothesis was to determine whether in a population of patients presenting to chest pain clinics throughout the United Kingdom, if routine CT coronary angiography with selective FFR-CT as a default test was superior in terms of resource utilization when compared with just traditional routine clinical pathway algorithms. Secondary objectives were comparing clinical outcomes and general well-being between the two groups at 9 months follow-up. On the left, we see the study flow, and there were a total of 1,400 patients that were randomized to the two arms. On the left, you see the data for the reference arm. On the right is the test arm. Patients in the test arm had mandated CTA, and if there was a stenosis of at least 40% in a major epicardial vessel, FFR-CT was performed for further assessment. You see the baseline characteristics of the two groups here. Now, when they looked at the results of the forecast study, FFR-CT was performed in 31% of patients in the test arm. So a third of patients, stable chest pain that had protocol mandated CTA ended up having a lesion that required performance of FFR-CT. And that FFR-CT was less than 0.8 in more than half of the patients in whom it was performed. So 57.3% of patients had an FFR-CT below the cutoff. When you looked at the data comparing the test group, the patients with the mandated CTA compared to the reference group, looking at the amount of patients requiring invasive coronary angiography was one of the endpoints. They found that there was 14% lower total invasive coronary angiography, or the ICA, in the test group versus the reference group, and that 22% fewer patients had invasive angiography in the test group compared to the reference group. So those were key findings. Total cardiac costs was not significantly different, despite the two differences in strategies here. And as a result, the investigators for the forecast study concluded that in patients presenting with new onset stable chest pain, the strategy of CTCA with FFR-CT, when compared to a strategy of routine care, it did not significantly reduce costs in patients presenting with stable chest pain in the British health system. They did find, though, it was associated with a significantly lower rate of invasive angiography, and they found that it was not associated with significantly different rates of adverse cardiac events. So those were the conclusion of the forecast study. To me, the big takeaway was the lower, obviously the lower rate of invasive angiography with improved risk stratification. However, it didn't impact in this study overall costs.
And as a matter of fact, as you said, Ivan, if you want, it is 1/3 or a percentage of patients, significant percentage of patient has an FFR CT less than 0.8. So these patients ended up going for angiography afterwards, which is that. Any comments from Dr. Uretsky, Dr. Blakis?
Yeah, I think, again, it's an interesting study. I mean, the question here, of course, is about the power to detect the difference. It is surprising to me, maybe it's because the UK, that you have 22% less in geography, and that wasn't cost saving, because maybe the prices there are a little less. In the US, I think if you decrease the angiography by 22% for diagnostic, that's probably going to be a more significant cost savings. So again, my case is they're probably more favorable towards this, but maybe the power for detecting difference in cost, which is the primary endpoint, maybe that was not there.
Yeah, absolutely. And this is kind of goes along the line of ischemia trial as well. When if you have somebody with stable ischemic disease, you have an X-ray utility now for CT, FFR to kind of more risk stratify these patients. All right, Ivan.
The next study that we'll jump into, everyone's heard about before, was DEFINE PCI. At TCT this year, they presented the one-year outcomes of patients with residual physiologic ischemia after PCI. So the one-year follow-up of the DEFINE PCI trial. So it was an international multi-center trial of 500 patients, IFR less than 0.9 in one or more vessel. These patients had PCI of all vessels with abnormal baseline IFR. And there was after angiographic confirmation of an adequate PCI result, there was blinded IFR and IFR pullback at the end of the procedure. And these are the inclusion-exclusion criteria. And the principal findings from the original DEFINE PCI study was that 24% of patients had post-PCI that was less than 0.9, indicating that there was significant residual ischemia despite an adequate angiographic result. Post-PCI angiography consequently poorly correlated with physiologic measures. And in a large majority of the cases, the residual pressure gradients were focal, therefore likely to be amenable to further improvement with additional PCI. So what was presented at TCT 2020 was the one-year outcomes from the DEFINE PCI. The composite primary endpoint was cardiac death, spontaneous MI, or clinically driven target vessel revascularization. And you see in patients whose final IFR is less than 0.95, there's a composite rate of 5.7% at 1 year. And that was compared to the patients with an IFR above the cut point of 0.95. It was 1.8, a significant difference. What's interesting, when you break down and just look at hard endpoints of cardiac death or spontaneous MI, you really see the difference here. There were no events when IFR was greater or equal to 0.95, compared with below the cut point is event rate of 3.2% at 1 year. So the take-home message from the one-year outcomes of DEFINE PCI, despite angiographically successful PCI, patients who are highly symptomatic at baseline without residual ischemia, characterized by an IFR greater than 0.95, tended to have greater improvements in their anginal symptoms at 12 months compared with patients who had residual ischemia. The investigators also concluded that a post-PCI IFR greater or equal to 0.95 was associated with less cardiac death, spontaneous MI, or clinically driven target vessel revascularization as compared with a post-PCI IFR that was less than 0.95. And lastly, the clinical effectiveness of IFR guidance targeting that IFR greater than 0.95 to identify and eliminate post-PCI ischemia needs to be studied in a larger prospective randomized trial. And that's what we're going to be seeing soon with DEFINE GPS, which hopefully will answer the question of how to optimally revascularize and how to achieve this greater final IFR.
Well, I have a question to the panel and to you, Evan, as well. After I read the study, I had a patient on the table. We did IFR, it was significant. We fixed it, and then we achieved 0.9, 0.1, 0.91, and then I want to push the IFR to 0.95, and it appeared again ballooning, and I couldn't make it. The best I could do is 0.994. And then I drop the IVUS to see if there's anything I missed and stuff. So going back between DEFINE PCI and target FFR is, as you know, they struggle to bring that with the strategy they did to bring that IFR or FFR higher up. So what is the best approach for these lesions? Obviously, we have to bring it above 0.95, but post-dilatation aggressively, drop an extra stent distal if there's a pullback issue. What is your protocol?
I mean, I think it's exactly what you did. It's, you know, physiology, people always ask you, should you image, should you do physiology? And it's the wrong question. It's both. They work synergistically. They're not competitive technologies. And the physiology tells you when treatment's needed. And that's both in the beginning of a procedure and at the end of a procedure. And the imaging will, you know, physiology pullback will guide you if it's a focal step up, diffuse, where you're looking into something distal to the stent or within the stent. But the imaging is going to show you, is this, you know, the why? Is there a stenotic gradient because there's under expansion? Is there a distal edge dissection? Is it just residual plaque? And it's using those two pieces of information together to optimize the outcome and treat the whole patient. It's just like if you're seeing a patient in the office, you don't just take a history, you don't just do a physical exam. It's using both together. And there's no reason why we should just choose one or the other, at least, you know, certainly in the US, where we have the, you know, resource, you know, available to use both modalities.
Yeah, and I think a couple of things is also between these two trials take home is, number one, always, I mean, I would say always, but I think we should always do post PCI physiology, and then we aim for a higher IFR value if you are IFR.
Right. Yeah, and you go after the best result you can, and you post dilate with high pressure noncompliance, and sometimes you're not going to get to normal always, but it's a matter of improving that result and giving the patient the best outcome that you can.
Absolutely.
So we'll move on. Yep. Oh, Dr. Balakis, you're muted.
No, one more thing I'm sorry to say. You know, sometimes you get a little hung up on the number. So in my mind, 0.94 and 0.95, you know, it's the same thing. I know we want to be 0.95, but, you know, I mean, you've done the best you could. It's not really that different, the two of them. So that's all.
Yeah. Now, it's always important to, you know, the studies obviously have binary cut points, but these are continuous variables in a patient. And yeah, you got to take into account the whole picture and look at these in practice. I do believe you should look at this as a continuous variable, not just as a binary cut point. And
these cutoffs keep going higher. I mean, as Dr. Balakis mentioned, I mean, we're going to keep chasing ourselves with a number, but if we have a strong endpoint, hopefully the DEFINE GPS will help us to kind of make a strong statement on that number. But we're really good, but if we do post PCI, IFR, or any physiology, I think we're leaving the patient with a good result. Yes, Dr. Risky.
I want to just make one small point. That is, we can get very close to an ideal number, but sometimes that requires a long amount of stent, a long length of stent. So I think as clinicians, we have to decide. Because we know that there's a negative effect of putting too much stent in. So I think you have to balance one versus the other.
Absolutely. Great point.
So, you know, moving on, the next study that we're going to be highlighting is the DEFINE flow study, looking at combined CFR and FFR assessment. And the hypothesis of the investigators for this study is that vessels with an abnormal FFR, defined as FFR less than the cut point of 0.8, but an intact CFR greater or equal to 2, will show non-inferior outcomes compared to FFR greater than 0.8 and an intact CFR when treated medically. The primary endpoint was a composite of all-cause death, MI, PCI, for CABG, and it was assessed at 2 years. So there was a total of 430 subjects that were enrolled with this protocol and followed out to 2 years. And they were stratified by their combination of FFR and CFR. If FFR was less than or equal to 0.8 and CFR was less than 2, They were revascularized by PCI, is typically done in contemporary practice. And if it was a different value, they were all treated with medical therapy initially, and they followed each of those patients and assessed their outcomes. You see here the number of subjects that fell into each quadrant and the mean FFR and CFR. Here we see the distribution. It's color coded, and you see based on a patient's FFR and CFR. You see there were 44% of lesions had a FFR that was greater than 0.8 with a CFR greater or equal to 2. So the primary endpoint, 2-year composite MACE, death, MI, or any revascularization, either surgical or PCI, found that the natural history was not non-inferior for FFR positive with CFR negative compared with FFR negative and CFR negative. So when
so much not non-negative. I mean, it took me some time to process that number in my head.
Yeah, it's something the not and with FFR CFR. This was the study that probably got the most discussion on for physiologically based study at TCT that got a lot of discussion, a lot of enthusiastic discussion from the panel there and after the fact. And it really takes time to process what it is and where these patients fall into. And here, obviously, they use binary cutoffs. And we were just talking about the importance of looking at the whole patient. But for obvious reasons, in clinical trials, you need to stratify a patient into certain boxes. And you see here with the difference in outcomes, the blue is the patients who were revascularized based on their invasive physiology. The patients who did the best, as we could expect, if they have a negative FFR, essentially with a intact coronary flow reserve, those patients had the best long-term outcomes here. Looking at a secondary endpoint of target vessel failure, you really see some of the differences. The patients who had FFR greater than 0.8 with CFR greater than 2 had the lowest target vessel failure. But what was interesting, the patients who were revascular, the revascularization is in the blue, but the patients who had the worst target vessel failure rates at 2 years, you see it's FFR less than 0.8, but a CFR greater than 2. So an intact coronary flow reserve with an abnormal FFR. They were not treated initially with PCI, and I think as a lot of us expect and what a lot of us see in practice, those patients end up having higher rates of target vessel failure. And I think in the majority of people's practice in the United States, if an FFR is performed and is abnormal, oftentimes they're not having that additional risk stratification where CFR is assessed in practice. But the primary conclusions of the investigators here was that the natural history when there was abnormal FFR with intact coronary flow reserve is not non-inferior to lesions that were FFR negative, also with an intact coronary flow reserve. They felt that FFR was a predictor for target vessel failure, and that there was no independent prognostic value when CFR was added in this cohort of patients. They found that prognosis also is equally poor if either the FFR or CFR is abnormal. And that makes sense. If there's an abnormal invasive physiology, there's going to be, it portends a worse prognosis. So, it's certainly a study you have to spend a little more time going through the details of, but the take-home message makes sense, and it's concordant with the rest of existing data that's out there.
That's great. I mean, thank you so much, Ivan, for these great highlights.
Yeah.
This is again, as you said, I mean, they spent some time discussing this trial. Number one, because of how much they diced the data and subgroup divided the patient into these different strategy, and also to digest these numbers and different quartiles. How do you do your practice? Do you use CFR in your practice, or is it routinely things, or this is something will change your practice, and how do you do it going forward?
I think the first thing is availability. Not everyone is checking CFR. You need it like anything. It needs to be readily available in the lab to use it. In my own practice, truthfully, right now, it's primarily just in studies that I'm checking CFR. A couple of my colleagues that I've worked with do a lot of work with this, and in patients that we're enrolling in studies for it, assess it. But I personally haven't been using it routinely in clinical practice.
Yeah. All right. Any comments, Dr. Blakis, Dr. Kravitsky?
I mean, for me, the clinical implications are very limited. I don't know many people who actually do CFR in clinical practice right now. I think it's mainly a research tool. So to me, it doesn't really change what we do. But again, maybe I'm a little biased.
All right.
Yeah, it's hard, doing a test that if it's not going to change your practice, it's always I think a little difficult to help with utilization and adoption practice. But so the last study that we're going to discuss that was presented at TCT, there was the combined OCT FFR trials, the combined optical coherence tomography and fractional flow reserve assessment to better predict adverse event outcomes in diabetic patients. And the hypothesis here was that medically treated diabetic patients with angiographically intermediate but otherwise non-ischemic by FFR coronary lesions will have significantly different clinical outcomes depending on the presence or absence of plaque vulnerability. And that was defined in this study by OCT-detected TICFA or thin cap fibroatheroma. With TICFA carrying patients, are thought to have the worst prognosis. So the design of the study was a prospective natural history study assessing all diabetic patients because they felt that that was a patient subpopulation with the fastest, most aggressive atherosclerosis progression. And the inclusion were any diabetic patients that underwent angiography for any indication with at least one lesion that had diameter stenosis of 40 to 80%, intermediate lesions that had FFR performed. So of the 547 patients that entered the study procedure, 112 had FFR that was less than or equal 0.8. And those patients also were followed for 18 months. But the interest in the combined OCT FFR study was this group on the left. So 423 had FFR that was greater than the cut point of 0.8. Of those, 390 had OCT that was analyzable. And those patients were stratified based on the presence of TICFA. We know TICFA is a high-risk feature, and they found that 98 had TICFA and 292 had no TICFA. There was one patient in every single arm that was lost to follow-up, but the remainder of the patients had 18-month follow-up here. The investigators for combined OCT FFR found that when you stratify patients by presence of TICFA, again in lesions that were FFR negative, there was a combined primary endpoint of cardiovascular death, target vessel MI, clinically driven target lesion revascularization or hospitalization for unstable angina. The difference of the composite endpoint was 13.3% in the patients who had TICFA as compared to 3.1% in the patients without TICFA. Looking at the breakdown of the composite endpoint, you see with target vessel MI, there were no instances at 18 months in the patients without TICFA as compared to 4.1% in the patients who had presence of TICFA. And you see similar imbalance with clinically driven target lesion revascularization as well. So the conclusion of the investigators here was that combined showed for the first time in diabetic patients that 1/4 of patients who had an FFR negative lesion still represented a high-risk plaque, and that was defined by OCT-assessed TICFA. The impact is the presence of a high-risk plaque. It's a strong predictor of future major adverse cardiac events, despite lack of ischemia, and that patients with high-risk plaques have significant increase in target lesion related adverse events as patients without TICFA already just at 1.5 years. And the ischemia and future adverse events represent two separate concepts. And it makes sense that ischemia is assessing what we have right now, and there's sometimes further investigation that's needed to figure out who's going to be at risk for future events. So the investigators concluded that combined FFR and OCT can improve the accuracy of high-risk lesion patient identification and therefore should be embraced. So putting together the data from really all 5 of these studies, and there were many other imaging studies that were highly impactful at TCT that due to time we can't go over today. But what I think putting it all together, what we know, physiology and resting indexes, there's robust evidence that supports using it at baseline when to treat a lesion. What I think is new by recent data and certainly supported by the data that's been presented most recently at TCT, physiology-guided optimization of PCI is critical. It's not just about assessing PCI, a lesion and figuring out, do I have to do PCI, but it's about doing a better job at the PCI and making sure we've reached an adequate endpoint. And I think the future of high quality PCI is going to involve both physiology and imaging and combining the 2 modalities to synergistically offer our patients the best results.
Thank you so much, Evan. Excellent summary of the most relevant physiology. As you mentioned, a lot to digest, but this is most of the highlight from TCT 2020. I agree with you. I mean, the main home take message is to do autophysiology pre and routinely maybe do physiology post and combine it with imaging to have the best answer and to give the patient best option before you take him off the table. With that, I would like to launch the first poll and also prompt our attendees that you can ask any question to the panel using the Q&A box. I will just launch the first poll for tonight related to the webinar. And with no further ado, I would like to introduce our second speaker, Dr. Emmanuel Berlakis. He's the director of the Center for Complex Coronary Interventions at the Minneapolis Heart Institute and chairman of the Center for Coronary Artery Disease at the Minneapolis Heart Institute Foundation. He's the author and co-author of over 600 manuscripts. I think majority of us on the call already read his papers and has written the Manual of CTO Intervention in the 2nd edition currently. He created the Manual of CTO YouTube channel and Manual of PCI as well, which is, I think, majority of us follow it, and myself, I learned from it a lot. He's on the board of Cardiovascular Innovation Foundation. As we know, this is our yearly meeting, happened every July, and last year was virtual, and an associate editor of the Circulation and editorial board member and reviewer for several journals and grant agencies. Thank you so much for being here, Dr. Berlakis, and please go ahead and share your slides, and the panel is yours.
Perfect. Thank you again. Thank you very much again. It's a great opportunity to be here with everyone tonight. Hopefully you can keep seeing my slides now. And what I'm going to say today is discuss a little bit about the practical uses of coronary physiology in everyday clinical practice. And this is how I like to break PCI into 14 steps. And the reason physiology is 12 is not because we do it at the end, but because not every case needs physiology. If there is clearly no disease, then you don't, or if you have a 99% ACS scalpel lesion, you don't. But it is a critical, as we heard from the talk from Dr. Slovmich, it's a critical step for contemporary percutaneous coronary intervention, and having experience in dealing with this is very important. So traditionally, we're thinking of physiologic assessment for determining the hemodynamic significance of lesions. However, now we're increasingly seeing with the studies we discussed today, such as DEFINE PCI, Target FFR, that it can be used as well for post-PCI assessment and ensuring that the best possible result has been achieved. And this is the algorithm actually from DEFINE PCI, in which the pullback is done at the end of standing, and then if there is a diffuse step up, then no treatment is done, but there is a focal step up, proximally or distal stent is placed. If it's a problem in stent, then post-dilation is done. And I think that's something easy enough that can be done on every day and hopefully get the number of optimal PCI a little higher. But going back to the basics, what would an operator want from a pressure wire? And in my mind, there are 2 things you want. First of all, to deliver it where it needs to go in an easy and fast way. And the second one is to not have a drift, because again, it does us no good, especially for the post-PCI assessment, or in the baseline as well, that do all this work, you spend 15 minutes, get the wire down, and then you pull it back, and now you have a drift, and now you have to repeat everything again. That can be very demoralizing for the operator, the staff, as well as the patient. So a few cases to discuss some of the concepts of what makes a wire useful and easy to use for coronary physiology. This is an example of a patient who was there down for CABATs. He did have 3-vessel coronary disease with lesions in the medial AD. There were disease in the circumflex and the first obtuse marginal branch. And this was a patient that was turned down for CABATs and was sent for percutaneous coronary intervention. The LAD were fairly convinced it was going to be significant, but we were not certain about what to do with the circumflex. And actually, we had planned to use the intravascular imaging with OCT, but we can see here the OCT catheter is actually buckling, would not deliver down the circ because of extreme angulation, more than 90 degrees going backwards. So after studying the LAD, the question became here, is the obtuse marginal and the circumflex significant? Actually, my initial thought is the circ is definitely significant and the OM may or may not be, but if it's not, then doing provisional standing would probably be the easier way to go. And we also used it in the LAD, as we discussed before, and interestingly enough, we had the same number as Dr. Alraies had earlier on, 0.94, with which actually we were very happy with. We didn't want to make it 0.95. But then, to our surprise, actually, the circumflex was not significant as well, which essentially simplified the case, and we were done much faster than we thought. So having a wire that can take those bends in an easy way without being deformed and deliver well is critical. And in that sense, the options wire does have the advantage because of the construction. Instead of having multiple electrical wires within the wire core, actually there's a single fiber optic cable that transmits all the signal, and as a result, torquing and manipulations of the wire are easier to perform. Also, it does have a soft tip and good one-to-one torque response. So for an operator, what you want is not know the logistics or the intricate details of the construction. What you want is get the wire, make your bend, deliver it easily, and I think this wire provides a good balance of ease of use and delivery in places that can be hard to use. This is another case. This is a patient who has a significant distal left main disease, and it's a left main bifurcation. It was turned down for bypass as well. There was no significant disease in the circumflex, so the plan here was to do provisional standing, placing a stent from the left main into the LAD. The stent was placed, jailing the wire. That was actually a workhorse wire. It was not the pressure wire, although increasingly we're jailing the pressure wire as well. And the question is what to do now, because there is now some disease in the ostial portion of the circumflex. So the question here is there significant disease in the circumflex? Do we need to do more optimization, or are we going to be okay? Of course, before putting more wires through, we have to do the proximal optimization technique. Otherwise, there is the risk of the wire going under the stent struts and then potentially deforming the stent we place right now in the main vessel. And to achieve that, one has to make sure the stent we choose can be expanded to be large enough in the beginning part of the procedure. So this is the proximal optimization technique. You can see that the stent is placed well. And then after doing that, then the question is, can we get an assessment of how it is? So we did intravascular ultrasound into the LAD, coming back into the left main. And we see here we have good coverage of the left main, but the question still remains, how is the circumflex? So here is an attempt to do pressure wire equalization. So this is the pressure wire, and then wiring was not easy, and sometimes it's not easy to go through a jailed vessel, and this was the circumflex, but eventually this was successfully performed. And then we did the DPR on there was a ramus as well. DPR on the ramus was 0.98, and then it took some effort, but actually we're able with the same wire to advance it all the way down into the circumflex. So we're able to get a DPR there, which was 0.91. You may say it's not perfect, it's not 0.94, but we were happy enough, and we didn't do any additional modification. So essentially, by doing post PCI in a bifurcation, assessing the side branch, that can really simplify the management, fewer steps and less risk of complication as well. Of course, we did have some hiccups here. The patient did have stent thrombosis during the case and required some additional treatment, but eventually a nice result was achieved. So again, for provisional stenting, having a pressure wire to assess the side branch can be a very useful technique for determining the need for additional PCI, and having a very torqueable wire can really facilitate the step. Moving on to the second key component, which is about avoiding the drift. This is a patient who has an LAD lesion. Actually, it doesn't look too bad. There is some diffuse disease in the LAD and no significant disease into the circumflex. And then when we do, however, the functional assessment, the DPR of the LAD was 0.79, which is surprising in a way because we don't really see any high focal lesion. And that's where actually the pullback is critical for determining the presence of a focal lesion, a focal step up or not. And this was actually the pullback in this particular patient. You can see there was a gradual increase in the signal. There is no focal step up. And these are the patients that you don't want to stent, because if you stent them, there is a significant risk that you are going to have jailing. You're going to need to stent the whole vessel, put like 100 or 150 millimeters of stent to cover the entire vessel. So this is an example of having no drift really helps. You want to do this pullback and have no drift, because otherwise you're going to have to repeat it. And again, the options wire does have a temperature dot compensation, a mechanism to minimize the drift. And that is why the drift with this wire is actually less than the other available commercially guided wires. So not having a lot of drift is critical, especially at the end of the case, we're doing pullbacks, for example, for assessing the vessel. Also, it is nice to be able to disconnect the pressure wire and manipulate it without having the constraint of the vessel, and then reconnect it at the end of the procedure for doing the final assessment. And then this is how the DPR is calculated, again, 2 beats. But it's key to have this lack of issues with pullback to have an accurate measurement, which is even more important for non-hyperemic indices than it is for the FFR itself. And then I think everyone is aware that pretty much every non-hyperemic index has the same correlation with FFR, about 0.89. That's the same for every wire. And the cutoff is the same, 0.89 for every non-hyperemic index. So it's not an issue of which index to use, it's an issue of which wire is the easier one to be delivered. And finishing on with a couple other cases, this is another bifurcation. The patient has significant disease into the LAD as well as in diagonal branch. And the question is the LAD distal to the mid-segment actually having significant disease or not? And it looks like there's not significant vessel. So it would be a Medina 1-0-1 bifurcation with disease being mainly in the proximal main vessel and into the side branch. This was confirmed. I mean, we did assessment prior to the case to the other vessels. There was an intermediate lesion in the circ that was actually not significant. As expected, the diagonal has an ischemic DPR. So our plan here was actually not to do a decay crash, which is what we typically will do in complex bifurcations, but instead, since there was no significant disease, do provisional stenting by stenting from the main vessel into the side branch, and then continuing with assessing the LAD after the procedure. So here it is, we have a workhorse wire into the LAD. We do have, we actually have the workhorse wire went in the diagonal, and we did decide to jail the pressure wire, the options wire into the LAD. And this is imaging afterwards to make sure that we have a good result into the LAD. And actually what we found is that there was an area of malapposition more proximally. We did stent from the diagonal, stenting the lesion there, and then came back and stented all the way from the diagonal into the LAD. And then by doing that, now we have what looks okay, but of course the LAD is jailed. And the question is, do we need to do additional steps here? We have, again, OCT after we did the proximal optimization technique to make sure that we've achieved a good stent expansion and we have a good stent strat apposition. And you can see here, it looks okay. However, more proximally, there was an area of malapposition. So additional post-dilatation was done with a 4.0 millimeter short compliant but non-compliant balloon using the stent boost to place it as accurately as possible. And then repeat OCT did demonstrate that actually we did have a nice result with good expansion of the stent. And now the stent was actually opposed all the way in the proximal portion of the main vessel. So now we do have a nice result by imaging. But how about the LAD? And again, this is the final DPR. This is 0.91. You may argue whether we should make it 0.95 or not, and maybe since it's a large vessel. But again, in this vessel, there is the risk if you start putting balloons and ballooning here, you might actually dissect this vessel, and then you might need actually an extra stent, reverse crush, or make things much more complicated. So we left it, the patient has done well over approximately 6 months. So again, this is an example of using physiology for assessing the Cybrands that can simplify the procedure and keep it provisional rather than a two-stent strategy. And a final example to show the importance of being attentive to the basic things. So before doing assessment, whether it's physiology or is with intravascular imaging, intracoronary nitroglycerin should be given to assess the vessel. So this is a patient who has an ostial LAD lesion. And the question is the lesion significant? Here is the DPR. So the DPR is 0.83. So clearly this is a significant lesion. Well, not so fast. So we gave nitroglycerin. And after nitro, you can see actually that area of the proximal or ostial LAD lesion looks much better. And guess what? The DPR is now normal. So actually, the issue here was that we had spasm. And that is why it's critical before doing physiology and imaging to actually make sure that you give a nitro and that this is done in as accurate way as it is possible. So always give nitro unless the patient is truly hypotensive before physiology. Otherwise, you get the same erroneous information as you get with angiography because the vessel has not had a chance to fully dilate. So to summarize, there are two things that an operator wants from a pressure wire. One of them is to get there fast and easily, and the second one is to not have any drift. And that's what the options wire really helps, has both characteristics, gets you there, and doesn't have any drift. So thank you so much.
Thank you so much, Dr. Blackus. Phenomenal talk, covering a lot of aspects in terms of physiology. We have one question from the audience, kind of will come into it later, we'll definitely address it. But we have a question related to the ostial lesion physiology. Aorto coronary ostium as well as branch ostium and physiology. Any comments on the capability of doing that and how reliable it is?
A great point. And again, those are challenging because the issue there is you may have a dampening of the guide catheter, which will artificially increase your index, whatever it's FFR or non-hyperemic index. The reason being you're dampening the pressure. Therefore, what happens is the denominator, which is the aortic pressure, becomes less, and then there's less difference from the distal wire pressure. So it's a critical factor, and it is important when doing that, actually not only for aortoostial, but any lesion, to disengage the guide a little bit to make sure you don't have any pressure dampening. Check the pressure waveform, make sure the pressure waveform is okay. This is exactly, as you mentioned, one of those other quality issues that you really want to have good quality. You don't want to have any dampened waveform because that can, again, negate the validity of the measurements.
That's great. You showed us a case, very nice case of jailing the pressure wire. Have you had any difficulty of retrieving the wire, especially if you had a pot with a 4.0 NC high pressure? Any difficulty retrieving that wire, any shearing of the wire, or any complication?
Yeah, great point. And this is actually an area that many people do have strong feelings. People don't want to jail wires because sometimes there is difficulty in pulling it back and wire entrapment might occur. However, I think the key part for those, the risk is very small, in my opinion. The second thing is that if you have difficulty retrieving, which will happen, at some point, any wire that we jail, pressure wire or not, is going to get some kind of pinch and difficult to pull out. The common mistake is to just yank it out, then the wire breaks, the wire unravels, and then you have a big situation. Instead, if you feel resistance, it's like the same with access. Never push, never pull. You just stop, get a small balloon, small microcatheter, all the way down to the wire where it's having the difficulty. And pretty much all the time after you do that, the wire will come back easily from the vessel without having additional steps. So in my mind, it's okay to gel the wire, but be very careful to not really pull very hard and break the wire if there's any resistance in pulling it back.
Yeah. And would that change the quality of physiology you're getting from the pressure wire?
Yeah, and I mean, it might. I mean, I think it's unlikely, but it could, and that's why, regardless, when we have to do a pullback at the end to make sure that the equalization has not been lost. So with any pressure wire, I think it's a good. I mean, it's critical for quality control to always pull the wire back and confirm at the end of any measurement that you do have still equalization between, 0.01, 0.02. It's okay either direction, and if that's the case, great. If not, then unfortunately we'll have to repeat the whole thing.
From your experience, last question from the absence wire, do you have to, before reconnecting the wire, do you have to do anything special to the back of the wire, like drying it out or with a dry gauze before you reconnect, or you just quickly connect it right away?
Yeah, typically I don't do anything. Now, if it's really wet and dirty, I might, but most of the time the back end of the wire looks okay. So we typically don't do any additional cleaning.
And one of the great things about the absence wire is you make it wet. You flush the end with salines, and rather than worry that it has to be dry like an electronic wire. So I find that really enjoyable when not to worry about that.
Absolutely, that's great. Great. Thank you so much, Dr. Blackus. We have one question from the audience as well. Say, have you used the Philips new solid core Omni wire? Are you seeing any different differentiating features when comparing it to Opto wire? Personally, I never made that comparison, so I'm not sure if the panel has any comments.
It's something we have it here. I think it's a great wire. It can also be used as a workhorse. I think as long as you are using a wire that can be used as a workhorse, right now we have multiple, high quality physiology wires. That's one of the features, but as you saw with Dr. Blackus, another thing to keep in mind is drift. Most labs in the US, realistically, probably don't have two workhorse quality physiology wires. So I think there's certainly room for expansion with all the invasive physiology wires. So, be it OpSense or some of the competitive technologies, there's a massive amount of utilization that can be increased. It's such a small segment of the market right now where invasive physiology is being performed, and certainly in post-PCI physiology. So I think there's certainly room for any of the high quality workhorse quality pressure wires. But one thing in the case, what was so nice in those complex cases, you saw people are shy away from physiology because they feel that it makes the case complex. Here you saw it took very complex cases and made it more simple by realizing what you don't have to treat. And I think those are really great case examples.
Great. Thank you so much, Ivan. With that, I will continue to take questions throughout the webinar again. Please put it in the Q&A box. We're moving forward to our third speaker, Dr. Barry Ritzky. He's a professor of medicine and director of interventional cardiology at the University of Arkansas for Medical Science and the Central Arkansas Veteran Health Care System. His current research interests include optimization of coronary intervention. He has participated at the national and international guidelines, participated in over 100 multi-center trials, and author of over 300 peer-reviewed articles. And from what I read and heard about Dr. Ritzky, he is a great coronary physiologist. With that, Dr. Ritzky, the panel is yours.
Okay, thank you very much, and thank you for that kind introduction. I was actually a little surprised at the unanimity of feeling about performing post-PCI functional optimization because in practice, it's not done very much. And I was going to try to discuss, if I can get started here. Its utility of functional assessment, whether one uses FFR, IFR, or DPR as an endpoint of PCI in order to improve long-term outcome. And I have 3 points in this regard to justify its potential use with the understanding that we don't have good randomized data on the subject at this time. So I think the first point, and the most difficult for interventional cardiologists, is that angiography is in fact limited in determining functional outcome after PCI when the vessel looks really normal. And I want to illustrate that point with an example. We have two different patients, relatively tight LAD in both of these cases. And we stented both here. And you can see that the outcome looks relatively good, but I can tell you that in one of these, the FFR is in a good range, and in the other, the FFR is not in a good range. And if you look at it for a second, you can decide which you think it is which, and here's the answer. So, you know, to my mind, this is very strong evidence to proceed with trying to optimize a vessel, because we know, as I'm going to show in the next slide, that the higher the post-PCI functional value, the better is the long-term outcome. So I call this a global observation because there are studies from all over the world that have shown essentially the same thing. On the upper left-hand panel is from our lab, which we show higher FFR as better long-term outcome. On the upper right-hand panel is from the FAME trials. From the lower left is from Korea, and from the right is from the DK Crush registry in China. And more recently, it's been shown that the non-hyperemic pressure ratios also can predict long-term outcome. On the left is a study we published last year on PDPA, and you can see the difference in long-term outcome. And as Evan showed with DEFINE PCI using IFR. And the third point is that sometimes we can improve the functional result by the methodology we use now. So this is from our lab. We've been doing actually post-PCI FFR and optimizing for almost a decade now. And in this study, which we published a few years ago, we found that there was about 20% of lesions of vessels which had low FFR at the end of the case, and we were able to decrease that percentage to 9%. And I want to emphasize this was our retrospective data. And this is a case from that registry, from that study. And you can see that there's really a very high-grade lesion of the PDA with some moderate lesions in the distal and mid RCA. And the FFR distally was quite low, 0.29. And then we stented that area. And the question is, are we done? And I think most interventionists that don't do post-PCI functional evaluation would say, some would say we're done. Some might want to stent some of these other areas. So we did FFR, and it was low at 0.69. So then we did what you might say a partial pullback, and we saw that there was a substantial gradient across the distal modest lesion. And so we stented it. And then after that, we found that with the wire in the same place, the FFR was still low. So then we did a formalized pullback. There was a gradient across the mid lesion. We stented it, and the final FFR was pretty good at 0.89. So on the basis of that retrospective data, we started a prospective registry. We call it the Functionally Optimized Coronary Intervention Registry, in which we use the pressure wire as the workhorse, and we measure pre and post FFR. And this is the strategy. We measure we measure pre-intervention. We do what we think is an angiographically optimized procedure. We then measure FFR with a pullback, and if the functional value is low, then we intervene if appropriate. And as been mentioned before, if it's a focal step up, we proceed. If it's diffuse, we leave it alone. And we published this year our results of our first 250 lesions. And basically what this slide shows is that it's a feasible approach. We were successful in all but one lesion, and we were able to do the FCI strategy in 92% of the vessels. So we think this is and as I should mention that we use the OpSense wire for this, which is a very good wire for in handling characteristics. And I wanted to point out here that the distribution of the lesions, which we included up to 99%, looked very similar to what was seen in the FAME trial. This is the FFR change for the entire cohort. And this is how they distributed in terms of FFR. In our series, we actually had 36.5% of cases that had an FFR less than 0.8. So we weren't surprised to see the results of the DEFINE PCI trial. And we had a little less than 50% that we call in the green zone, because we found in our study that if you get an FFR 0.86 or above, the results are better than the lower values. So we found that on pullback, we were able to do further intervention on 34.5%, which is a third of the vessels. And we were able to take the FFR from 0.73 to 0.80. And this is interesting because this number is quite similar to what was seen in the target FFR trial that Evan presented. Now, in this is a case from that registry. And you can see in this case that this is an RCA with multiple moderate lesions. The FFR distally was low at 0.66. We stented the distal segment of the right coronary. And so the question is, should we stent the more proximal one? That is to say, put metal in all the way near the ostium. And after we put in the distal stent, the FFR was as low as when we started. We did a pullback, and again, there was sort of a graduated, in a way, increase, but the largest uptake was between the mid and proximal. So we put in a second stent there. And the FFR was now 0.87. So what we learned is we can do the procedure of FCI, that when we do it, and we do it in the way our protocol was, that there was a really high incidence of ischemic FFR, despite the fact that angiographically it looked quite good. And that doing a pullback, we could improve the FFR in some patients. Only a third, which was a bit disappointing. So what we're doing now is we're continuing the registry. We're doing the same approach as the first registry, but if the FFR is not in the green zone, then we image and treat with imaging as well. Now, I'll show you a case here. This is a very simple case of a proximal LAD. The FFR again, 0.6. Put in a stent, and the balloon is still in there, but you can see that it looks pretty good. Looks about the same size as the angiographic appearance of that part of the vessel. It is a little bit in the ischemic range distally, 0.79. By the time we get to the stent, it's 0.91, and there's a trans-stent gradient of 0.04. So what we did is we took a look with IVUS, and we saw that the reference diameter was actually 4, and the area was about 13 millimeters squared. And our MLD, we put a 3 millimeter stent in. The MLD was 2.8, MLA was 6.3, 89% of predicted. We then post-dilated it with a 3.2 non-compliant balloon. Now the MLD was 3 millimeters, and it was 100% of predicted in terms of the MLA. However, the trans-stent gradient was still 0.03. The FFR distally was 0.80. We made a little tiny bit of improvement. We then went with a 3.5 non-compliant. We now have distally FFR of 0.82, slightly above the ischemic threshold, not tremendous, but better than before. The trans-stent gradient is now 0, and we decided to stop at that point. So finally, the critical step, although there's intuitive attraction to this approach, we really don't have the randomized data to support it. And of course, there may be some downside risk to doing this that enthusiasts like myself and maybe other panel members maybe downplay a bit, but we really need a randomized trial. So DEFINE GPS is, as I understand it, in the draft stage now, but as it proceeds forward, I think it'll help us a lot in understanding how to proceed. So thanks for your attention.
Thank you so much, Dr. Ritsky. You covered a lot of aspects of physiology, and I mean, congratulations for your work. I mean, obviously, as you said, you're not surprised with the findings with the DEFINE PCI or even target FFR. So what is your algorithm? As you said, you pull back. If you have a focal lesion or a stent, you post dilatation, and that's Dr. Berlakis alluded to. But let's say you have, what is your protocol if you did not achieve your target FFR?
Well, I think what we do is routinely, let's say our FFR is low at the end, we do a pullback. And as Manos mentioned, we have to be sure that there's not drift. And if the drift is more than 0.03, then we re-equilibrate and do a pullback again to make sure that there's really a low FFR. But if there's low FFR and it's clearly a step up, then we have to see where the step up is. Is it in a place where we angiographically don't see a lesion? Or it's somewhere where there is a lesion that we see and we've underestimated the importance of it. In those cases, then we'll probably stent, in the latter, we'll probably stent that area and do it again. If we're really not sure, then we'll image. And I think one thing we didn't do very much in our first registry was do a lot of imaging. And now we're doing much more imaging in the current cases. So that's really what our protocol is now.
Perfect.
And the other aspect, the other point I want to just raise is, I think it's an important point is, I think that we're systematically underexpanding stents when we do it angiographically. And I think that the closer we can get to a trans-stent gradient of 0, the better our outcomes will be, particularly when the stents are proximal, because the small gradient proximally will make a big difference in terms of the final FFR.
That's great. So post-dilatation, again, pull back, make sure there's no drift, and aim for a higher FFR possible. Again, as Dr. Berlakis mentioned, don't hang up on a number, but again, if the higher FFR, the better chances you are giving this patient before leaving the lab. We have a few minutes. I launched the polls here, but I just want to bring one more, if there's any other trials that kind of change your practice or was an eye-opener at TCT. One of the things that came up is the Shockwave trial. What's your take on it? What's your the findings of the technology and how this is going to change your management of severe calcification? We'll start with Dr. Berlakis.
Yeah, no, thank you very much, Chadi. So I must say, this is technology that everyone is very excited about. The results were very nice. 11% residual stenosis is very good for these very complex lesions. I think 2.5 to 2.6% complications, very low for these complex lesions as well. So this is very encouraging. We've been using intravascular lithotripsy off-label, the peripheral balloon in the coronary, which is a pain. So we're actually looking forward to having the actual coronary lithotripsy balloon. I mean, the concern in my mind remains about deliverability. Is it going to be deliverable through some of the tortuous calcified vessels? But overall, I think it would be a nice tool to have available.
Absolutely. Dr. Ritsky?
I don't have any experience with it, but again, like Manos, it sounds like a great tool when we get our hands on it and see how it works.
Yeah.
Sure. Ivan?
Yeah, no, we participated in the trial, had a great experience with it. I think it will be a game changer in the way people modify calcified plaque. It's certainly only useful if you're able to deliver it there, but there's going to be a tremendous amount of lesions that hopefully will be getting adequate lesion preparation, which hadn't been appropriately treated before. And I think that's going to certainly impact final stent expansion, which is what's driving a lot of these future target lesion related events. So I think it's going to be a great tool to have on the shelf. there's a lot we need to learn about how to use it, when to use it, and what the optimal way to use it is. And that's really where I believe intravascular imaging is going to be key. But I'm excited to hopefully get it in the US market pretty soon.
Yeah, absolutely. We have it in the peripheral. We don't have it in the coronary yet. We kind of use a couple of in the off-label use. I agree with Dr. Berlakis, deliverability may be an issue, but hopefully with the lower profile, with the newer, when the FDA approved and we have the newer technology. Do you, in terms of the comparing it with atherectomy, like are they complementing to each other, or are they kind of can do the job of each other? What's your take? Let's start with Ivan, backward.
Yeah, I think it depends on the morphology. If you don't do intravascular imaging, I think you just treat it. It's calcified lesions, and calcified lesions need lesion prep. But when you use intravascular imaging, you can see the morphology, and if it's concentric superficial calcium, it's going to be a great lesion for shockwave or intravascular lithotripsy. Whereas if it's very eccentric calcification, calcified nodule, in my opinion, that's probably not the best lesion for lithotripsy, and atherectomy, mechanical atherectomy might be a better approach. And you just don't know that from an angiogram alone. And that's really where imaging plays a key role. I think atherectomy will certainly be used for lesions that are difficult to cross. And if an inadequate outcome is not achieved with that, then lithotripsy can be incorporated. But where lithotripsy, I think, is going to really change the game in so many centers without surgical backup, centers where they're not comfortable using atherectomy. Very often they're putting in a stent without adequate lesion preparation, and I think it's going to be a really useful device to try to prevent stent expansion by adequate lesion modification. And now I'm looking forward to more clinical data specifically on its role with treating in-stent restenosis as well.
Dr. Berlakis, you treat a lot of calcification and complex lesions. Do you think that these two technologies complement each other? Each one has its own indication, or they can be used in one lesion based on the imaging?
Good point. Obviously we don't know enough yet because we haven't really used it extensively, especially in non-study lesions at this point. But I do think they're complementary. So for example, actually the one subgroup that I think would be great is the balloon dilatable lesions, but actually those were excluded from Disrupt CAD3. So there are some lesions that are going to be an issue. But for balloon uncrossable lesions, still you need atherectomy, otherwise it will be hard to deliver any sort of balloon there. And then I'm not so sure about the efficacy if you don't have circumferential calcium. This seems to work great if you have a lot of circumferential 360-degree calcium, but maybe if it's not as circumferential, I'm not sure if it's going to be as effective. So again, it's something very good to have. I think atherectomy remains an important tool for complex PCI, and the balance will be sorted out in the days and years to come.
Dr. Ritsky, I want to move a little bit to a different topic, but since we are now in Sky Shock, what is your algorithm, or how much you trust your physiology in patient with cardiogenic shock to do like a complete revasc for somebody after treating the culprit?
Well, I mean, that's an interesting question. I'm not sure that I don't really have much experience using it in shock, honestly. In the shock patients, I've kind of reverted to being as efficient and trying to do to minimize anything other than try to open up the lesions as fast as I can.
So your protocol is you treat the culprit. If there's any kind of intermediate lesions, you stage it, bring back the patient when he's more stable.
Yes,
absolutely.
I do.
Dr. Berlakis?
Yeah, no, I agree. I mean, the same in the same boat. I think it's something that the calculation of any index, right, depends on the pressure, the filling pressure in the ventricle on the right side. If this is high, then you have to adjust for it. And I think that's very hard to do. So I don't think they're accurate, actually. Probably physiologists should not be done in shock patients with high filling pressures because it's not going to be accurate anyway. So I think that's not the place to use it.
Absolutely. So we have a question. What about DEB for ISR? Some patients have several dozen of stent with multiple layers of metal. What option for these patients? what's your protocol, Dr. Pulakis? If you see somebody who has ISR, had 2 layers already of stents, and is coming for again significant lesion, what's the options are?
Yeah, great question, and it is a challenging clinical problem. Now, as you know, unfortunately, it's like a lithotripsy. We don't have a DCB in the US for coronary use. You have the peripheral DCBs that are a disaster. Delivering this, I mean, you have to have a 4 vessel and have an 8 French guide and super support. So I don't think it's a realistic lesion for most of those patients. What is available in certain centers, not every, but many centers, is brachytherapy. So I think with the multiple layers of stent right now, the first step in my mind is to do imaging and make sure it's not underexpanded. If it is, then you have to expand it as much as you can. If it is expanded and it's just neointima, then the best thing we have is brachytherapy. If TCB becomes available, that would be great. Another option in some patients without heart failure can give cilostazol, plus minus the results, but maybe it can help.
Dr. Ritsky, how is your protocol?
Well, we have the same frustration as everybody on the panel. We have no drug-coated balloon. We also, in our lab, we also don't have laser. And I'm told that if you can use a laser and you can burn out some of the materials between the layers of stent with contrast, then you might be able to do something good there by expanding the stents a bit. Maybe somebody else could comment on that.
Yeah. Ivan?
Yeah, down when I was in DC, we use laser a lot for ISR for underexpanded stents with some very favorable results. Obviously, also is a large brachytherapy center, but I'm curious to see how intravascular lithotripsy will perform in these lesions, though we don't have any data in the US at least on that. And DCBs, I've seen a couple of people use it off-label, but we also obviously don't have DCB availability here. And I think the key is doing intravascular imaging anytime you have ISR, even more so than with calcium, to figure out what the underlying mechanism is, what's causing that restenosis, so that you could stratify if they need brachytherapy, another layer of stent, or something altogether like laser.
Great. I think the best therapy for ISR is to prevent it from happening by doing more physiology pre and post, and do proper imaging to characterize the lesion and make sure you did debulking or any modification to the lesion before you deploy the stent. Hopefully we'll see less of this, but again, it's frustrating point. We have a couple of minutes. I just want to see your take, Dr. Pulakis. You mentioned DCB are terrible in the periphery. Voyager PAD, they presented at TCT, they did a sub-cohort of study of patients who had DCB, and it was 1,300 patients plus. And they showed there's no difference in mortality in between patients who received drug-coated devices compared to those who did not receive drug-coated devices. Do you think that's enough evidence, or we need to put with the meta-analysis that we had before, or we need a specific trial looking at this hard outcome?
Yeah, just to clarify my previous statement, I didn't say it's terrible for the periphery. I said it's terrible for the coronaries.
Okay, right, yeah.
For the coronaries. That's just to clarify, because that's a very hard statement. I'm going to get in huge trouble for this. But no, I don't do peripheral, so I cannot, have much opinion on this. But I can tell you from the data, I think still in my mind the concerns remain. Impact, SFA, there was actually higher mortality on the Viva meta-analysis. There was still a signal of actually there was significantly higher mortality in the RCT meta-analysis. So in my mind, I remain very concerned in terms of the long-term safety of those devices. So if it was me a patient, would I want to have this? No.
Dr. Ritsky, do you do peripheral intervention? And what do you think of the analysis presented? Voyager PAD.
No, I'm going to pass on that question. I don't do peripheral procedures, so I'll pass, okay?
Yeah, I think you got the coronary group here, but I also do not do planned peripheral procedures. And more data is always great, but I personally haven't been following that as closely as the coronary.
We did some discussion on it for again, it's a subgroup analysis. It wasn't the main focus of the analysis looking at mortality in DCB cohort of patients. But this was a nice signal, it's a positive signal. But again, I don't think it's enough to change the practice and take the label for a black box warning for these devices. All right, I think with that, I think we covered all the questions. We covered a lot. this webinar and others will be recorded. We'll be posting this on the All in Physiology, Coronary Physiology YouTube channel. Thank you for all the audience, and thanks so much to the speakers for your time, for preparation, and for giving us your kind of top of the line coronary physiology in your practice based on the most recent literature.